Uh, Very good morning to all the audience who have joined on an early Sunday morning. I appreciate your presence. All of us have started mastering the act of good cataract surgery with good early post-operative outcomes in a standard case, and that doesn't seem to be a very big challenge for most of us trained in cataract surgery. I think now we are moving on to the next stage in mastering and getting better outcomes, that is in the complicated cases. And until now, all cataract surgeons wanted to hold on to anything and everything that was associated with cataract. And therefore, we end up causing, suboptimal outcomes, not giving the best outcome to the patient. So I think this course is mainly designed to highlight the fact that we need to work together as a team and leave the ego issue aside. If I'm not good at deciding whether the patient needs a retina treatment or not, I should team up with my retinal colleague. I should team up with my glaucoma colleague. I should team up with my cornea colleague and take a holistic approach to the patient so that in the long run, it will work the best for the patient. So we have a stellar faculty, including all subspecialties included. And I would encourage everyone to post their questions in the Q&A box. We will have sufficient time for interaction and discussion with all the experts. So without wasting much time, I would like to invite our first speaker, Dr. Aditya Sudalkar, who will be talking to us about how do we tackle a patient with the cataract and uveitis both together. So over to you, Dr. Aditya Sudalkar.
Thank you so much, Shell. And let me just quickly share my screen. I hope it is visible.
Yes, it is.
Okay. So without further delay, as Shell said, let me go to the presentation. And just to put things in perspective, let me just seems to be. Yeah, I'll just start with a case illustration, put things in verse. So this was a 55-year-old lady who came to us with a complaint of sudden decrease in vision in the left eye and metamorphopsia since 15 days. It was painless but progressive. She was a known case of diabetes mellitus type 2 and fluctuating control, and there was nothing positive in the family history apart from her mother having undergone cataract surgery. The anterior segment examination was quite okay, except for the presence of grade 2 nuclear cataract. So she had been diagnosed as having diabetic macular edema elsewhere and had been started on topical nepafenec drops and had been advised anti-VEGF injections. So this is what the picture looked like. So, if we look at the clinical photo, there are obvious exudates here, but then there are also areas which, of what appears to be choroiditis, and they seem to be scattered all around the posterior pole. The OCT confirms the presence of subretinal fluid and some intraretinal thickening. And this is what the angiography looked like. So we have the classic early hypofluorescence followed by the late hyperfluorescence here. So based on a diagnosis of multifocal choroiditis, this is just a blown up image of the superior-temporal quadrant. We advised immunosuppressive therapy, but because of her diabetic status, we advised her against steroids. And we gave her a local injection of the dexamethasone implant, or Ozurdex as it's called, and with great results. There was a recurrence about 6 months later, and she received a second injection. And ultimately, this patient was scheduled for cataract surgery, and she underwent uneventful cataract surgery with a third injection as prophylaxis. So this patient was part of our clinical trial, which compared the dexamethasone implant to systemic steroids. And as we know, uveitic cataracts are a technical challenge. And apart from the usual anterior segment issues, such as, say, posterior synechia, poorly dilating pupils, fibrotic capsules, there are also associated retinal complications, cystoid macular edema, epiretinal membrane formation, recurrent uveitis, and so on and so forth. So this is what we managed to publish about 5 years ago. And on similar lines, we also published on the role of the dexamethasone implant in Irvine gas syndrome, which is along the same spectrum. So, our calculations were based upon a 10% difference between the two groups. That is, one group that received systemic steroids and one group that received the dexamethasone implant without systemic steroids. So this was our purpose, to compare the safety and efficacy of intravitreal dexamethasone implant with systemic steroids as prophylaxis with cataracts secondary to or associated with intermediate or posterior uveitis. So we did not study anterior uveitis in this particular study. This trial was sponsored in its entirety by Allergan. And coming to the demographic characteristics of the patients, as you can see, the instances of intermediate and posterior uveitis were more or less evenly distributed. So the change in visual acuity and the change in subfield thickness was more or less similar for both groups. And essentially what we were trying to show is that the dexamethasone implant is non-inferior to systemic steroids. And in many cases, it is a boon, because systemic steroids come with their own set of complications that, this particular group has several comorbidities, and we don't want to enhance those. So this is the second publication that we managed to get out with a French group. And this was just a retrospective study of all eyes treated with the dexamethasone implant and who had intermediate or posterior uveitis. Now, this complex graph, I'll just quickly sum up. What it shows is that there is an initial improvement in vision if you inject Ozurdex for all of these patients, followed by a drop, which would correspond to the point in time when these patients develop cataracts. And then the vision goes back again once they receive uneventful cataract surgery. And in most cases, as we know, cataract surgery has been largely perfected. And more often than not, you end up with very good outcomes. Now, the other problem with the use of dexamethasone implant that often, many people have reluctance to use it is high IOP. And what this graph shows us is that we have divided patients based upon their either presence or absence of glaucoma. So there was either no risk or no glaucoma. And if you see, only 9.4% of patients manifested an Iop spike. With prior history of glaucoma or ocular hypertension, about 16% manifest an Iop spike with Ozurdex. Patients on monotherapy or history of filtering surgery, it is more or less the same. And the same goes for patients on maximal topical therapy. So overall, the risk of Iop rise with dexamethasone is not very high. And, it's not just about the dexamethasone implant. There are other local steroid options. We live in a country which, has to finance its own therapy, and not everybody can afford the implant. So triamcinolone acetate also seems to work equally well, provided it is used correctly. So this is just, an elaboration of our technique of injecting posterior subtenon triamcinolone. So what we do is we actually go in, incise the conjunctiva and the tenons and inject with a visco cannula, so that number one, that you're in the right plane, and number two, there is very little chance of perforation or intraoperative complications. Now, we prefer this method based upon our publication, which I'll come to shortly. And this is just a video of how to inject Ozurdex with cataract surgery. So what is important is to have a well-formed globe, and viscoat or any visco dispersive works better. You generally remove the viscodispersive after injecting Ozurdex to avoid hypotony. Now, based upon our publication, what we have seen is that the closer the implant or the steroid molecule is to the anterior chamber or the pars ciliara, the higher the chances of Iop spike. And correspondingly, if you inject posterior subtenon, there's a very low chance that you'll end up with an Iop spike. So even for the Ozurdex implant, the further away it is from the pars ciliara, the lesser the chances of Iop spike, among other indications, of course. And one way to achieve it is to direct it, as we saw in the video, direct it posteriorly towards the optic nerve to achieve maximal distance between the two. So here you can see this patient manifest an Iop spike within 3 days of injection. And what we see here is that it is flush with the ciliary process. So this facilitates the entry of the steroid molecule in the anterior chamber and causes trabecular meshwork alterations, which lead to Iop rise. One other problem with Ozurdex is that people are often scared to go in with such a big needle. It's a 22 gauge needle, which is higher than our which is thicker than our 23 gauge sclerotomies. So in this case, what we saw is that this is not a worm. This is the entire Ozurdex implant under the conjunctiva. So somebody just penetrated the conjunctiva and left it there. So, there are many issues associated with Ozurdex, but overall, topical therapy is a very good alternative to systemic steroids. It can be supplemented with systemic steroids at any point in time. It lessens the incidence of post-op complication. And of course, we have cheaper also, alternatives to the intravitreal dexamethasone implants, such as triamcinolone. So thank you very much for your attention.
Thank you, Dr. Aditya, for that extensive, presentation, and congratulations on the tremendous scientific work that you have been doing with so many publications related to the topic. I think I had 2-3 comments and wanted your feedback. One is, you're right that cataract surgery has improved tremendously, and probably in a quiet eye, the debate is whether you actually need anything perioperatively, whether it's systemic steroids or atropine or intravitreal injections or subtenon injections. But I think having been part of the trial that you conducted with the intravitreal steroids versus systemic steroids versus nothing, the difference that you see on post-operative day 1 is stark. It may not, manifest at 6 post-op BCVA, but the difference that you see on the next day, first 2 days post-operatively is really amazing. It's something to see. I mean, it's as good as a virgin eye that has been operated, even though you may have used retractors and so many other things intraoperatively. So I think that's one thing that I would like to pass on as a take-home message. And I really liked your video on the subtenons, posterior subtenons, because what most of us as general ophthalmologists or anterior segment people have been seeing is people giving it in the outpatient clinic. And we have seen quite a few patients, scary patients with those subtenon depots with uncontrolled glaucomas, where we had to remove the depots, AGV, so on and so forth. So could you just elaborate on how that makes a difference? Yeah.
Right. So just to take your first, point, I agree. The quietitude or the quietness of the eye that we see with the dexamethasone or subtenon injection post-operatively cannot be compared. And if it has been a one-off event, say the uveitis has just come in once, maybe years ago, there's very little chance of it getting reactivated. But cataract surgery itself induces inflammation. And that inflammation can be very well taken care of by steroids. Number 2, for the subtenon thing, what happens is that generally the patients who manifest an Iop spike do so because that triamcinolone, those molecules have inadvertently entered the subconjunctival space. If it is actually subtenon, very few, undoubtedly, people will manifest an Iop spike if they are, steroid responders. But the instance is very low. Number 1. Number 2, it can be well controlled with topical therapy. And number 3, worst case, we can always, give a flush, a subtenon flush, and try and remove the depot. So my preferred site is the supranasal quadrant, because then you know where it is, and then it's easy to remove. But it can be put in any quadrant. But the closer it is to the fovea, obviously, the better its effects.
Thank you very much, Dr. Aditya. So now we move on from the back of the eye to the front of the eye. And this is something that is very common, all of us face, particularly from patients who have a history of a lot of outdoor exposure, particularly in rural India. Patients having cataract along with pterygium. So to highlight how to go ahead and manage such cases, I would like to invite Dr. Vandana Nath to share her experiences.
Good morning, everybody. And thank you for this privilege. Yeah, can you see my screen? So this is a very common problem that we encounter, presence of a pterygium. So how do we achieve refractive cataract surgery in the presence of pterygium? See, nowadays, the patients who are undergoing cataract surgery, they demand superlative visual performance after the cataract and with the least dependence on glasses. Now, if we are tackling a patient who has a pterygium along with the cataract, how do I know if it has an impact on my IOL power calculations? And if so, what do I do? So when we do the preoperative evaluation, and we do a very extensive preoperative evaluation to reach the refractive status that we want of the patient. So not only do we need a good biometry, we need to choose the correct IOL for this patient, but we also need to evaluate the pterygium in great detail. by the site, the size of the pterygium, and the grade of the pterygium. So the preoperative evaluation includes a detailed history. Does this patient know that he has a pterygium? How long is the pterygium been in the eye? What is the visual requirement of this patient? How active is this patient? Does this patient drive? Does this patient have very fine visual requirements? The status of the fellow eye, which is very important. And of course, you can never undermine the effect of the counseling of a patient. So what are the options that we have? In the presence of pterygium, should we operate only the cataract, leave the pterygium alone? Do we operate the pterygium first and then the cataract? And the cataract with the pterygium combined surgery, is that prudent? So let's see the different case scenarios. These are our own cases whom we have operated. So this is a 76-year-old gentleman who's come for cataract surgery. He's retired, leads a sedentary life, doesn't have very demanding visual requirements. And we are going to leap upon this nice grade 3 juicy cataract, and we might actually miss the little villain lurking nearby. This is a long-standing pterygium, and the patient knows that he has a pterygium. Sometimes in our haste to go ahead with the cataract surgery, we may miss these kind of pterygia. And this is, you can see it's a thin avascular pterygium, and you can make out that it's a long-standing, causing a little bit of a scarring there. Now, is this going to impact my K readings? So measuring keratometry is the most important first step in our biometry. Ideally, in such cases, if you have noted that there is a pterygium, ideally more than one keratometer should be done. And both the readings should be reliable and repeatable and in sync with each other. So what we like to do is any pterygium usually always gives rise to some kind of an astigmatism. So we want to know the magnitude and the axis. So we like to use a manual keratometer, which we do ourselves. It gives us a lot of information. You can use the autokeratometry, and we rely heavily on the optical biometers. So the keratometry which you get from a Lenstar or the IOL Master, we rely on that. But not only the magnitude and the axis, we want to know whether the astigmatism is regular. So for that, an additional topography at least should be done to find out if the astigmatism is regular. So these are the manual keratometry Myers. If the Myers are regular, if they can be superimposed accurately on each other, that means you know it's a regular astigmatism. And look for the bow tie pattern on a topography to find out if the astigmatism is regular. Now in this patient, we got the magnitude of astigmatism approximately 1 diopter. And this is the eye trace aberrometry reading. We find this a very useful tool. You can see the hemimeridional flattening where the pterygium is. And this pterygium also not only gives rise to an astigmatism of 1 diopter it is giving rise to, but it is also giving rise to these aberrations. So very commonly, there are higher order aberrations that a pterygium causes, and this is a coma and trefoil that you can see. These are the corneal aberrations. This is the corneal aberration profile on the eye wavefront aberrometry. So this is a very useful tool for us to get the aberrometry profile of a patient, even with such a small atrophic pterygium. There are many studies which show that the pterygium has and its size have significant influence on higher order aberrations of the eye, especially on the measured total coma and total trefoil, as we can see in this patient. So my IOL selection, I have reliable K readings, and I know that it is not a very large astigmatism, but it is an irregular astigmatism. My IOL power, I'm going to try and predict so that I don't leave behind any residual spherical refractive error, but I know I'm going to leave behind a 1 diopter of astigmatism. There is going to be certain ocular surface disturbances. So my choice of IOL will be a simple non-aspheric IOL like an SA6080. Why not an aspheric? See, we are going to leave behind any refractive error that you are going to leave behind. It is not a good idea to implant an aspheric or a multifocal or a toric, because the patient has an irregular astigmatism, the patient has higher order aberrations. So the quality of vision is going to get deteriorated with any of these three IOLs. So an ideal lens for this patient would be a non-aspheric, and the patient was very happy with the aspheric lens implanted. Now coming to the second scenario, this first one where we have left the pterygium alone, the second is a stage surgery. In which cases would we do a pterygium surgery first? So there are many studies which show that a pterygium excision can significantly reduce most of the pterygium-induced higher order aberrations that we saw earlier. Topographic changes after primary pterygium excision are associated with the pterygium size, and a pterygium advancing over the pupillary area may require almost 6 to 12 months for corneal topography restoration. Please note that this is a very, very significant point when you are planning a pterygium and a cataract surgery. So let's consider this second case of a 57-year-old female who has a very fleshy pterygium. Now she wants a combined surgery of a cataract and a pterygium. Because this is very fleshy and it is a pterygium of not a very long-term onset, it is a recent onset, it is a fleshy vascular pterygium. So let's see how this pterygium is causing a very, very high astigmatism. If you can see the tracy astigmatism, it's causing almost a 4 diopter of astigmatism, and the higher order aberrations that you can see in the form of coma and trefoil. Okay, so we counseled her for a pterygium surgery first. You can see that the cataract is not too advanced. We counseled her and said that she would benefit by doing a pterygium surgery first, and we did a pterygium surgery with a conjunctival autograft. She was also happy cosmetically for the surgery. And then after 3 months, we planned the cataract surgery. Not only did her astigmatism reduce from 4 diopters to 2 diopters, it became a more or less regular astigmatism, and therefore we planned her a toric IOL, and the patient was counseled about the post-operative surface symptoms, lubricating drops given for a longer time, and post-operatively uncorrected visual acuity was 6/9, and the patient was very happy. So if pterygia are small and they do not impact the K readings, they can be left alone. If they are large enough to adversely affect your keratometry readings, remove the pterygium first and then plan for the cataract surgery, and wait for a minimum of 6 to 8 weeks before planning the cataract surgery. Let's take this third case, a 58-year-old female with a large recurred pterygium. The primary pterygium surgery was done in 1996, and after that this pterygium has recurred and she has been living with this for the last 15 years. Her best corrected visual acuity is finger counting 2 meters. Now, unless and until this pterygium is removed, and now she has come to us for the cataract surgery. So unless and until we remove this pterygium, we will not be able to plan the cataract surgery. So this is after the cataract, this is after the pterygium surgery with expert guidance from Dr. Fogla, where we had to do a very large conjunctival grafting. But ideally, this is the patient. In spite of having an operable cataract, we need to keep a close watch. We told her that we would wait for 6 months for this corneal topography to stabilize. The last case, this is a patient, a 65-year-old male with a cataract who did not want pterygium surgery. This is a very long-standing pterygium that he had. And please note that his mesopic pupil was only 2.5 millimeters, and maximum this was the pupil that was dilated. The other significant thing was his other eye, which was operated elsewhere. He has a best corrected vision of 624 with a full thickness macular hole. You can see the iris atrophy. Now, don't be compelled to put a multifocal. This is not a candidate for multifocal, and because we are leaving this large pterygium, and you can see over here with the topograph, the pentacam readings, that he has almost a 5 to 6 diopter of astigmatism. But in this small pupillary area, which he has a very small pupil, if you can see, this dotted line is his pupillary area. Within that pupillary area, he has a more or less regular astigmatism. So we did a large T9 correcting toric IOL, and the patient had 6/6 with a residual minimal refractive astigmatism, and patient was very happy. So only in special conditions you should do
Really
a
sorry
combined
to interrupt,
cataract.
ma'am.
Yes. The use of postoperative steroids can delay healing and avoid treating it as a refractive surgery if you're going to combine a cataract and pterygium. So in many cases, we do not combine the cataract and pterygium surgeries. And pterygia do lead to deterioration of quality of visual performance, and they increase ocular wavefront aberrations. So each patient has to be dealt with as a separate case and customize the visual requirements for each patient. Thank you so much.
Thank you very much, Dr. Vandanath, for this wonderful description of so many different varieties. And I think it was an eye-opener for most of us that we treat as general pterygium very casually. That, okay, move it during cataract surgery. And that's something patient is also very easily, readily accepting that, you know, you're doing one surgery, why don't you do that along with it? Highlighted very correctly that in most situations we need to stage it, and pterygium is a separate disease. It's not just one skin that has grown on top of the cornea. You need to treat it very methodically, very scientifically, and it's not just the Snellen's acuity that matters. It's the quality of vision that the patient is seeing through that matters the most, not just before but particularly now in today's time. So thank you very much once again for that excellent presentation, and now we move on to a presentation which needs no introduction. The speaker needs no introduction, not just in India, but the world over. I would like to invite Dr. Rajesh Fogla, sir, for discussing his views on achieving clear corneas in patients having endothelial difficulties or dystrophies along with cataract surgery.
Thank you, Shahid. I shall be talking about cataract surgery in eyes with Fuchs dystrophy, decision-making, no financial disclosures. Fuchs dystrophy is a bilateral corneal dystrophy affecting the endothelium, has an autosomal dominant inheritance with a female preponderance. Clinically, under diffuse illumination, you can often miss this unless you make a slit and look at the decimus membrane for the guttae changes. The guttae are seen better on retroillumination. On specular microscopy, you will see the dark spots. On anterior segment OCT, you can see a thickening of the decimus membrane, and regional pachymetry will show increased corneal thickness. The guttae lead to loss of endothelial cells with variation in size and shape. You can get posterior stromal folds leading to epithelial edema, and then finally subepithelial fibrosis and superficial vascularization. The symptoms of Fuchs is the corneal dystrophy and the cataract are almost similar, except that the early morning blurring of vision is a symptom which is very specific to having the corneal edema. The clinical decision is whether to do the corneal surgery or do a combine or do the cataract surgery first. In a normal cataract surgery, there is 8 to 10% loss of endothelial cells, depending on the density of the cataract, the axial length, anterior chamber depth, and the pupil dilatation. And a lot of these eyes with compromised endothelium, you tend to use the soft shell technique of a combination of dispersive and cohesive viscoelastic. The study looking at the cataract surgery in Fuchs dystrophy by Sietzman, they found that eyes which had preoperative pachymetry of 640 microns, 22.2% went on to require a keratoplasty, whereas eyes with a preoperative thickness of less than 640, only 2.4% required a subsequent keratoplasty. The advantage of doing a cataract surgery alone is that you can avoid all the complications that are associated with a corneal transplantation, namely endothelial keratoplasty, no need for frequent follow-ups, long-term use of medication. However, the disadvantage is that with passage of time, as the disease progresses, you can have visual deterioration. If you decide to do a cataract surgery, ideally phacoemulsification is preferred, but depending on the density of the cataract and the overall situation, you can choose to do a manual small incision or extracapsular cataract surgery. In eyes which have very shallow anterior chamber, sometimes I prefer to do a limited pars plana vitrectomy, which increases the anterior chamber depth, increasing the working space, thereby reducing the endothelial cell loss. Remember to put in a hydrophobic intraocular lens, as the hydrophilic lenses can develop opacity with the air fill with endothelial keratoplasty. Because of the to overcome the hyperopic shift, you can aim for -1, -1.5 as the post-op refractive target. Use very sharp knives because when you're making your paracentesis, the decimus membrane, usually the attachment is not very tight. So you can detach the decimals both at the side port of the main incision. Use the soft cell technique, VSS. Avoid intracameral medications because the endothelium is already compromised. You may not want to use medications to either dilate the pupil or stain the capsule, or at the end of the surgery using intracameral antibiotics. I would prefer to secure my wounds rather than try and hydrate them, because while hydration, you can further detach the decimus membrane. And it's always advisable to leave a mid-size air bubble at the end of surgery. So if you do have some partial detachment near your incisions, this air bubble can help reposit the decimus membrane. You can use steroids post-operatively with a greater frequency. Sometimes you need hyperosmotics. Watch out for the intraocular pressure. And if you do develop edema, it may take sometimes 8 to 12 weeks to resolve. So this is how the fused dystrophy progresses. Well, ideally, if your corneal thickness is less than 650 and your cell count is more than 1,000, you can think about doing a cataract surgery alone. If it is more than 650, but the cell counts are still between 800 to 1,000, you can do a cataract surgery, but understanding that there may be a greater risk of postoperative edema. But if the PACI is more than 650 and the cell counts are less than 800, maybe better to perform a combined surgery or do an endothelial keratoplasty first, followed by subsequent cataract surgery. We often use central corneal thickness as an indicator of endothelial function, but there have been some recent papers where on tomography, they have found that looking at the regional pachymetry increase in the central corneal thickness. And if you look at the posterior elevation, you find a focal posterior depression, which can be earlier indicators of the Fuchs dystrophy. And on serial tomography, you can find out if the disease is progressing. Similarly, looking at the corneal thickness, the ratio between central and peripheral cornea can also give you an idea about the disease progression. You have newer anterior segment paucity, which gives you a 3D imaging, whereby you can look at the guttae and maybe quantify them. The decimal stripping only can be performed when you have the changes, the guttae changes are located to the central 4 to 5 millimeter area only. So you just go and do a decimal stripping in the central 4 to 5 millimeter area. It's pretty much like doing a capsulorhexis. Here you are doing a decimatorhexis. And after that, you put your patients on topical steroids and also topical rho kinase inhibitors like ripasudil 0.4%. And they found that the edema resolves over a 1 to 3 months period, and patients recover good visual acuity, and they may not, the Fuchs dystrophy may not progress in the immediate period. But if you have advanced changes like this may not work because the guttae extend all the way to the periphery. You may need to think about doing endothelial keratoplasty, which is much better than traditional penetrating keratoplasty. You have better refractive outcomes, lower risk of rejection. So here the basic surgical procedure involves removing the unhealthy decimus membrane, followed by inserting donor lenticule. Like in DSEC, you have the donor lenticule with some amount of stroma, whereas in DMEC, you have just the isolated transfer of the decimus membrane. So once you place inside the eye, the donor disc is, or the donor DM is unfolded, and then you use air or gas for tamponade to hold the donor disc in place, and that basically completes the surgery. Combined surgery with cataract and endothelial keratoplasty, especially DMAC, the cataract surgery has had no adverse impact on the outcome of surgery or the endothelial function. This is a patient who has undergone bilateral, in a sequential manner, a phacoemulsification with endothelial keratoplasty, and at 2 and 3 years, you can see that has good visual acuity unaided of 6.9, improving to 6.6, and cell counts are also pretty good. There's a patient who has had, with Fuchs dystrophy, who has had a cataract surgery alone and a non-resolving corneal edema. They had a DMEC done and is maintaining good vision at 3 years with good endothelial cell count. These are again some of the other cases where this has been done. This is a young patient. She's 45 years old, and there are no lenticular changes with Fuchs. So we went ahead, just did a DMEC alone, and patient recovered good vision. The advantage of doing DMEC in a phakic eye is that a subsequent cataract surgery, you can plan for the the newer lenses, either the toric lens, or you can place your multifocal lens as well. That's the change you see on anterior segment OCT. The refractive shift in DMEC is much less. Initially, immediate post-op, you may see a small hyperopic shift. That's resulting from the faster resolution of the central corneal edema. So that makes the posterior curvature more steep. And when the peripheral corneal edema resolves, this curvature gets back to normal, and that reduces the short-term hyperopic shift that you see. So in this series, where in phakic DMEC, only 4.7% developed cataract, which required surgery, and all I achieved 20/30 or better, and were within plus or minus 0.5 of the target refraction. And the endothelial cell density did see a decrease of about 20%, but which was not significant. So if you have Fuchs dystrophy, you can do cataract surgery alone. If it fails, you can plan for endothelial keratoplasty. If it is limited to the central area, you can just do a decimal stripping only, followed by a cataract surgery later whenever the cornea decompensates. You can either combine the surgery, or you can go ahead and do the endothelial keratoplasty first, and then do a subsequent cataract surgery at a later date. This is just a flow chart just to show you that if you have patient with Fuchs dystrophy, if you have an asymptomatic patient, you don't do anything. If you have a symptomatic patient with a clear lens, then you can look at the guttae. If they are limited to the central area, you just do a decimal stripping only, which can be successful or unsuccessful. If it is unsuccessful, you can consider DMEC. Or if the guttae extends beyond the 5 millimeter and the anterior chamber depth is sufficient for a safe cataract surgery at a later date, then you can consider DMEC. But if the anterior chamber depth is less than 3 millimeter, then no point doing a DMEC alone, because the subsequent cataract surgery may result in an increase in endothelial cell loss. If there are lenticular changes, you look at the pachymetry and the endothelial cell count. If the pachymetry is less than 650 and endothelial cell counts are above 1,000, you can still go ahead with the cataract surgery alone, place a hydrophobic IOL. You can aim for a slight myopia in the target refraction, and then subsequently perform DMEC whenever necessary. Yeah, and if your pachymetry is more than 650, then you choose the other options. That's in conclusion. I think that's what I've covered. Thank you. Thank you for the patient hearing.
Thank you very much, sir. And as always, it's a visual delight to see the photographs and the patient outcomes that you presented. It's really out of the world. So I had just a couple of questions or doubts that I wanted to clear. One is, there's a lot of talk about use of these Rho kinase inhibitors in Fuchs early who don't have cataract, or who are not, we are not planning for surgery. So is there any prophylactic role of using them for months together beforehand?
Yes, there have been few reports wherein people have given Rho kinase inhibitors in the early stage of Fuchs, and then they have, on serial specular microscopy, they have seen a reduction in the guttae, or maybe they have seen increased cell count in the center. But this has not been consistent. Even in my own experience, I have not found any significant difference. And in fact, the Rho kinase drops are not very, patient-friendly. They produce irritation, redness. So patients also stop after some time. They feel that it's not helping them in any way. We have also seen surgeons using Rho kinase in patients who have corneal edema post-cataract surgery. So if you already have a pseudophakic bullous keratopathy that's not going to get better, then adding Rho kinase does not give you any benefit. So I think maybe in the first 8 to 12 weeks is the time when you can try using Rho kinase along with the steroids. But on serial pachymetry or anterior segment OCT, if the edema is not resolving, then there is no point in continuing it on a long-term basis.
And so the second question I had was, do you change your, the do you continue lifelong topical steroids post excellent DMEC or a DSEC, or do you stop after 1 year, 2 years?
For DMEC, there is a study where they discontinued the steroids after a year versus the other group which continued with the drops. And they found that the group that did not use steroids after 1 year 6% had an episode of rejection, which was successfully managed. So you have to look at, 94% patients not having a rejection if they discontinue. But with DMEC, with the low risk of rejection, even if the patient discontinues steroids after a year or more, I think it's quite safe. Patients can discontinue, but not with the other forms of endothelial keratoplasty or penetrating keratoplasty.
Thank you very much, sir, for this excellent insight. Now we move on to our next presentation. I would like to invite Dr. Deepak Bhojwani, who will be talking to us about one of the most common problems that affects most cataract patients in the same age group, that is diabetes. And many of them do present with cataract and active diabetic retinopathy. So I'd like to hand over the podium to Dr. Deepak Bhojwani, who will be discussing the role of a retinal surgeon in diabetic eye disease with cataract.
So a very good morning, everyone. First of all, I would like to thank AIOS Support Organizing Committee for organizing such a virtual fest. And secondly, I would like to thank Dr. Shell for including me in this wonderful comorbid IC on cataract. So I'm Dr. Deepak. I'll be talking basically about managing the retinal aspect of a patient and a diabetic patient who is planning a cataract surgery or who has been diagnosed with a cataract. So I'll be sharing a few of real-world scenario cases which will help us to imbibe practice patterns in the managing in such patients, diabetic patients who have multiple comorbidities. I'll focus on the retinal aspect only in most of the cases. So let's talk about a tale of two simple, straightforward cases. One is a 55-year-old gentleman, recently diabetic for 2 years, has a significant cataract, no retinopathy at baseline examination, as compared to an aged lady who has been diabetic for the last 22 years, has a visually significant cataract, no retinopathy to begin with. So on examination, if you see, if you have to do a meticulous retinal examination along with your cataract examination. So whenever you see a cataract patient and a diabetes, it is must to rule out a posterior pole disease, because it is the posterior pole which is going to be important for giving the vision to the patient back. So for examination, sometimes a fundus photo can give you a clue that is no retinopathy. Still, we have advanced technologies like OCT to document clinically microscopic changes, sometimes early retinopathy, which may not be seen on fundus photos. You might be able to pick up very early changes in OCT, and that is why it is mandatory for this diabetic patients who are a little bit more prominent, for who are telling you that I would like to go a premium IOLs. It's better to get a mandatory OCT examination done in such cases. So post-operatively, the young gentleman, 55-year-old gentleman, he was quite happy with multifocal IOL placed enterally, and posterior segment also OCT also shows the same what we had in pre-operative. But that lady, aged lady, unfortunately at 3 months she was not happy, and on OCT we are seeing some changes happening because of retinopathy. On fundus photo she didn't had any retinopathy to begin with. After cataract surgery I could see some background retinopathy to happen with. So what went wrong? So I reviewed the surgical records back. The cataract surgery was flawless. It was performed by Dr. Shell, and I could not find any error during the pre-operative period or even on the first month post-operative period. So what went wrong? So diabetic retinopathy can develop after cataract surgery. It is very important to know this. So one of the risk factor for developing a diabetic retinopathy is cataract surgery. Also, there are many other risk factors which would I like to highlight. You can put it on the checklist whenever you are seeing on a diabetic patient who is planning a cataract surgery, like duration of diabetes, patient who have early onset juvenile diabetes, patient who have comorbidities like nephropathy, neuropathy, patient having blood pressure issues, cholesterol issues. So these are the red flags for developing retinopathy after cataract surgery. So newer associations, aged patients, women, and patients who are using AC inhibitors, statins, dyslipidemia, and insulin lesions, these are the newer risk factors once we get more insight into the diabetes per se. Why does cataract surgery causes retinopathy? Because cataract surgery itself can cause compromise in blood retinal barriers, because being a surgical trauma, and also the inflammation. If you have an eventful cataract surgery, it may initiate a cycle of progression of diabetic retinopathy. And what is the incidence? So overall incidence of pseudophakic CME after cataract surgery is less than 1%. But if you have a diabetes, if you're a patient undergoing diabetes, the risk of macular edema developing after cataract can be as high as 50%. So you might be very aware of this. So when to plan a cataract surgery in a diabetic patient, please do not wait for too long, especially with patients who have PSC. A classic diabetic cataract presents with PSC. And if you have a long-standing case, the nuclear sclerosis along with the plaque forms, which will cause more interventional procedures during the surgery, which will end up not with a not happy patient. If the fundus is not visualized clearly, always inform the patient that there may be post-op surprises, no matter what you do. Preoperative workup, this is a basic checklist, the highlight being a patient counseling. So the patient should be counseled that diabetes per se can cause retinopathy, cataract, corneal problems, other problems also including glaucoma. So he should be made aware about the concept called as diabetic eye disease. So he should be made aware that it is a small part of a big spectrum of disease which is called as diabetic eye disease. Once the patient accepts that he is suffering from a diabetic eye disease, and cataract surgery will help him little bit more, especially if there are no any other comorbidities. So he will accept your whatever lenses, whatever post-operative regimens you have. It's very important that if there is any pre-existing retinopathy or diabetic macular edema and there is no visually significant cataract, we have to treat the diabetic retinopathy, the retina, first before you perform a cataract surgery. Do not ask these patients to undergo cataract surgery first without treating the retinopathy pre-existing, because they may not be happy. So now coming to the treatment options for macular edema. So overall preferred, if you have a central mode, fovea involved retinopathy, the standard treatment of choice is intravitreal injections. It can be anti-VEGF or steroids. If you have a non-foveal retinopathy, laser is the standard of choice. But overall mandatory is systemic control, which should be emphasized at every visit. Considering steroids and anti-VEGF, this is $1 million question. And if out of pre-operative, the patient is not planning cataract surgery, anti-VEGF is the first standard choice. In the perioperative period, if the patient is planning cataract surgery, we have found out that steroids are a better drugs as compared to anti-VEGFs. So timing, when do you plan intravitreal injection in a patient who is planning cataract surgery in a diabetic patient? Recent reports have told that the best timing is intraoperative, concurrent injection, let it be anti-VEGF or a steroid implant. It's very important whenever you have a patient with diabetic retinopathy and he comes, you have to distinguish it from pseudophakic CME. Pseudophakic CME, because the prognosis is very good, it is self-limiting disease, compared to DME where you have a background retinopathy. So coming down to the second case, he's an aged gentleman, known case of retinopathy, has received multiple injections. Now he's been advised cataract surgery. So on retina, everything was good. The patient underwent cataract surgery, but he was unhappy because he did not find any visual gain. Why? Because diabetes per se is the vascular disease. So whenever you have a mismatch between the cataract grading and the visual acuity, best corrected visual acuity, you have to suspect some kind of ischemia in diabetic patients, and which is better shown on angiography or OCT angiography, which is now available. So we have to be aware of poor prognostic indicators that pre-existing retinopathy is a red flag sign. And if there is a poor presenting visual acuity, despite the cataract grade or retinopathy doesn't meet, always suspect the ischemia. Coming down to the third case, sometimes whenever you have DME, all these patients do not need injection. So when you have a tractional component like this patient who had a tractional component, only performing cataract surgery with injection will not work. You have to first get rid of this traction. So for traction, we have to plan a retinal surgery first if the cataract is not very demanding, or if the cataract is very significant, you can plan a combined cataract surgery along with the retinal intervention in the form of removing the traction, in the form of vitrectomy and peeling all the membranes on the scaffolds, epiretinal membrane and the IM scaffold. So these are surgical patients. Not all diabetic patients will need a injection per se. Coming down to the fourth case, so here you can see he's an aged gentleman, he is a diabetic patient, multiple interventions, he comes for a cataract treatment. I want you to highlight on this posterior segment OCT. So if you see, I cannot distinguish any of the retinal layers distinctly. So he basically has a foveal atrophy. So if you are seeing a patient with a foveal atrophy, these are not the candidates for premium IOLs, and they should be counseled for real world visual expectations. So they should not be expecting a miracle happening after cataract surgery, because the vision potential, whenever you plan a cataract surgery, you have to see a vision potential of the patient. For assessing the visual potential, you have to see the optic disc and the macular also. Finally, a last case like this, if you see a severe retinopathy, these are very, very big red flags for a cataract surgeon. Whenever you see a vitreous hemorrhage, tractional retinal detachment, florid neurovascularization. These are straightforward cases for retinal intervention. Unless and unless the retinal colleague tells you that you can vision is very cataract is very significant, he is not able to see a retina very clearly. Only in such specific scenarios you can plan a combined surgery. Otherwise, you have to schedule these patients for retinal intervention first to see what is the vision potential. Then later on, you can plan your cataract surgery if the patient is accepting your suboptimal intervention in the form of retinopathy. Lastly, to end it, we should not forget the diabetic patients is a risk factor for glaucoma as well as other diseases like AION. So we should, whenever you are seeing a retina per se or a cataract per se, we should always be aware of all the comorbidities associated with diabetic patients per se. So to conclude, the real world problem with diabetic patients is we are not living up to patients' expectations, because the patient expects that this is just a cataract surgery, but diabetes is not like that. So we have to educate the patient that you are suffering from a diabetic eye disease, not a straightforward cataract, not a retinal disease also. And we have to see eye as a whole, not as a cataract, glaucoma or retina, anything. And please, we don't be overzealous in performing refractive cataract surgery in patient with diabetes. Thank you very much for your patient listening.
Thank you, Dr. Deepak. That was an excellent comprehensive overview of all the different forms that most of us are presented with in our day-to-day clinic. I think 2-3 important points that I learned from your presentation. The first and foremost is don't jump onto cataract surgery, particularly if the patient is visiting you for the first time. So it's very tempting that the patient has come with a complaint of decreased vision. He's been told somewhere else that you need cataract surgery, and he's come to you to get cataract surgery done. So, you feel you are almost obliged to operate him. But what we need to explain to the patient is that the cause for his decreased vision is not cataract. And therefore, any form of surgery is not going to make life any better for him. So even if you feel you can do a combined procedure of doing a cataract with intravitreal or something like that, first, I would suggest for a new patient, always treat the retina first, so that gives them a time to realize over a period of few months that they have two separate diseases inside the eye. So it's important to separate out the two diseases that they are suffering inside the eye. I think the second most important point I learned from your presentation is the role of imaging, and particularly OCT. And I think OCT has really revolutionized the way we manage and counsel most of these patients. So sometimes, even if it means spending out of your pocket, not charging them during the preoperative evaluation, or include that as a part of your preoperative checkup, it's very important to highlight some of these changes that are occurring at the foveal level, which are very, very easy to miss on 90D and 20D examination, even in the hands of the best retinal surgeons, because of the lack of contrast and the cataract visual disability and defect. And the third, I think, most important point that you highlighted is that even if the patient doesn't have a very, high diabetic retinopathy before cataract surgery, there is a chance, even in spite of an uneventful cataract surgery, of developing CME or diabetic macular edema post-operatively. So forewarn these patients, and there's a very nice multi-center study done by the ESCRS group known as the pre-med study, where they saw different topical drops regimen, and they found that the patients undergoing steroid along with NSAIDs in the post-op had the lowest chance of post-operative macular edema in diabetic patients who had no retinopathy before cataract surgery. The second in line was NSAIDs alone post-operatively, and the third highest incidence was with only post-operative topical steroids. So I think that's also one point that all of us have, as cataract surgeons, need to keep in mind what we are giving post-operatively in such patients. But thank you for this excellent comprehensive overview. Thank you once again, Dr. Deepak.
Thanks, Shel. I totally echo your views. Thank you very much for involving in your IC. Thank you.
Now we move on to the next presentation. Again, a very common topic, and again, not a very reversible disease, that is open angle glaucoma and cataract surgery. Do we go along with it like Terrigen combined? Do we separate out? What do we do? So I'd like to introduce Dr. Retinal Pandit, who is a trained glaucoma specialist, currently working at Choitharam, Indore. Over to you, Dr. Retinal.
Good morning, everyone. Thank you, Dr. Shail and AIOS for having me on board for this instruction course. Today, just a moment. Yeah. Today I'll be talking about open-angle glaucoma patients with grossly depressed visual fields, advanced disc damage, and requiring multiple AGMs to control the pressure. Say one such patient walks into your OPD with a visually significant cataract. As a cataract surgeon, you are tempted to see this cataract and you want to knock it off. And at the same time, you also wish to help your patient see better. And this is when the real dilemma starts for a cataract surgeon, that is, whether to go ahead with a cataract surgery alone or to combine it with a filtration surgery. So how to decide? To be able to answer this question, first we need to understand what is the impact of each of this intervention independently over the concerned comorbidity. So if we talk about a cataract surgery alone, only cataract surgery is not going to help much reduce the pressure in the long run. Also, over 1/3 patients are likely to develop a postoperative Iop spike, which is just going to make a bad scenario worse. A cataract surgery done today may have a slightly negative influence over the success rate of a future trap. Coming on to the combined surgery, this combined approach is not as powerful as a trap alone to control the pressure, and it also comes with a slightly higher rate of complications. If you compare it with a cataract surgery, definitely here you have to explain your patient to deal with a slightly longer post-operative recovery period. Now let us make a head-to-head comparison between the two interventions, and surprisingly what we see is the combined approach offers minimum IOP reduction in the long run. Also, if we compare both the interventions, there is no significant difference in terms of improvement in the visual acuity, occurrence of clinically important complications, or requirement of a resurgery to control the pressure. Now let us look at what is happening in the real world. As per a survey conducted by the American Glaucoma Society, they have reported that the number of surgeons wanting to do a cataract surgery alone are almost twice the number of surgeons preferring to do a combined surgery. Thus, from the discussion so far, what we learn is none of the intervention is absolutely superior to the other, and in the real clinical practice, we need to have a holistic approach, and our decision making needs to be dependent upon a variety of factors, such as the age and life expectancy. A younger patient is going to require an aggressive approach from your end because here you have the responsibility to retain the vision for many more years to come. We have to look into the socio-economic status of the patient because adding in an intervention means adding to the economic burden. We need to assess how visually demanding is the profession of your patient. We need to see how good is the IOP control. A patient whose IOP is under good control with a single or say 2 AGMs, you really don't want to put in a filter and disturb the balance, especially when you don't know for how long or how well the filter is going to function. Compliance with the medications is very important to assess. Poor compliance or significant side effects of the therapy are an indication for combined surgery. Assess the rate of glaucoma progression. Rapid progressors again will need an aggressive approach. And sometimes you also need to look at the patient's preference. Now, to add further clarity to this discussion, I would like to walk you through 2 case scenarios. So the first scenario is of a 70-year-old male who is living with glaucoma since the past 30 years. With 2 AGMs and a good compliance, his IOP is in mid-teens and his fields have been fairly stable since many years. Now, this gentleman walks in with a grade 3 cataract. It seems things are pretty much under control for him, and here you are justified if you do a phacoemulsification alone and let the medical therapy continue to take care of the glaucoma part. Next is a 65-year-old male having glaucoma since the past 20 years. His one eye has already succumbed to glaucoma. He's on maximum therapy, still the IOP is not under control, and with this end-stage glaucoma, he walks in with a brunescent cataract. Here, things are quite out of order, and his one-eyed status, end-stage glaucoma, and brunescent cataract are enough to give you a nightmare. But here, you have to be bold enough with your decision-making, and only a combined surgery will help retain the vision in this one-eyed patient. Coming on to our next case, he's a 56-year-old male, having glaucoma since the past 6 years. He's on multiple medications and has very poor compliance. His IOP keeps on fluctuating and his fields have also been progressing in the past. He comes with a cataract and he also is keen to know whether an additional surgery can be done to control the pressure. Well, scenarios similar to this are an ideal situation to go ahead with a combined surgery for two reasons. First, here the patient is himself motivated to get a combined surgery, and next, this patient is definitely going to require something more than just medical therapy, if not in the short run, then in the long run, to control the pressure. And thus, in similar scenarios, we can go ahead with a combined surgery after thorough counseling. Thus, to summarize, no strategy is absolutely superior over the other, and we need to have a tailor-made approach for each patient, and we need to decide based on our own experience and a combination of subjective and objective components unique to each patient. Thank you.
Thank you for that wonderful comment. Which keeps coming up in my mind from time to time, that the principles of cataract surgery and filtering surgery are almost exactly opposite. In cataract surgery, you want to try and maintain as everything as closed as much as possible, and in filtering surgery, you are trying to open up another area. So, do you think the results of cataract surgery or trabeculectomy vary based on whether you do trab before cataract surgery or trab after cataract surgery, or combined?
Definitely. So, in my opinion, the best thing to do would be a trab, decent after a good time after a cataract surgery. Like, say if possible, if the situation allows, we can leave a good amount of, say, 6 months or 8 months after the cataract surgery, and then put in a filter rather than trying to do everything together. Because as you said, you just mentioned, it's very right that the principles are exactly opposite, and though a lot of combined surgeries are done, but still, if you have a chance, it's always better to separate both the procedures.
Okay. And because I'm not a glaucoma expert, I keep attending some of these nice symposium, and there are now more and more. There are quite a few advocates who are suggesting primary valve surgery instead of trabeculectomy, particularly for combined. They find they are more predictable, giving in their outcomes. So, do you have any view on what surgery would you prefer, particularly for a combined case?
Well, for primary glaucoma patients, it's always better to do a trap first. But definitely, when you have a secondary glaucoma patient, the valve is definitely going to function better. Or if you have another scenario where you can do a primary valve is a pseudophakic patient, because that will give you the liberty to put the tube in the sulcus and avoid all the corneal complications later. So in phakic patients, I don't think it's a good idea to go ahead with a primary tube for just a glaucoma patient.
And do you change your strategy of use of, say, mitomycin or Ologen or no agent if you're combining surgery versus if you would do otherwise?
It remains the same. We use mitomycin in the same concentration for the same amount of time as for a combined surgery or a trap done. It remains the same.
Wonderful, wonderful. Thank you so much once again for this extensive presentation and the comprehensive overview of the decision making. Now we'll move on to another sort of not a very common situation, that is traumatic cataracts. And like we know, trauma itself is a Pandora's box. So we'll be limiting ourselves to the management of traumatic cataract and not to other diseases caused by the trauma, like the retinal issues. At the outset, I do acknowledge we receive research grant support from Alcon Laboratories, but has no relevance to this presentation. So this is a 17-year-old male, a history of trauma with a wire while playing in the fields before 1 month. And he's been referred to us for cataract surgery. If you look, this is photo slit. If you notice here, there's a large split in the anterior capsule. The lens matter is already in the anterior chamber. So if there is the moment you see white cataract just a few days later of a trauma, it has to be 100% a split in the anterior capsule. Otherwise, it doesn't become fluid so quickly in 10-15 days. And if you notice, this is probably the sealed entry wound. The iris has got a synechia along the area of the split capsule. If possible, particularly in older children, you must try and pre-operatively assess as much as you can. So pre-operatively, we wanted to know if there is already a pre-existing posterior capsule defect or already lens matter that is spilled on, like in the anterior chamber, towards the posterior chamber, so that we can plan a better surgical strategy and be prepared for. See, fortunately, we found that the posterior capsule was intact all through. That was one relief when we started off. It's important that you stain all of these patients, and it's also important that we create some sort of semblance of a capsular excess in the area of the capsule. So this entire area is split, and we create an opening to create at least some sort of strength in the remaining half of the anterior capsule. Having done that, most of these cataracts are soft liquid in young individuals, so irrigation aspiration alone is enough, and phacoemulsification is hardly needed. It's important once again to use low. Notice we are using a very low bottle height, and even while changing hands, you'll see that we inject dispersed viscoelastic to make sure that the chamber doesn't shallow. So having done the cataract, is how we go ahead IOL implantation. Now this is a intact posterior cap. So you have a half open bag with synechia to the iris in the rest of the simplest and straightforward option would be just go ahead with a single piece IOL in the bag, since at least half of the bag is intact. Second is that the single piece may come out from the open half of the bag. Single piece IOLs can be lethal if they end up in the sulcus. So go ahead with a 3-piece IOL in the bag or sulcus. But like all of us have seen that over a period of time, most of these patients do very bad as far as the post-operative inflammation, their stability. Many of them get a pupillary capture in the anterior plane, so on and so forth. So is there something else that we can think of without causing too much disturbance to the other anatomical structures? And having experience with pediatric cataract surgery in optic capture, we find the concept of creating a posterior capsulorhexis, even in a case of an intact posterior capsule, it helps us to posteriorly optic capture the IOL through the posterior capsulorhexis. So you will need special microincision rhexis forceps, good cohesive viscoelastics, and slowly but surely keep changing your hands from one side to the other to achieve perfect ergonomical comfort. And you should be able to achieve a reasonable size posterior capsulorhexis. So now you have an half open anterior capsule, a nice posterior capsulorhexis, and therefore now you can go ahead and consider placing a 3-piece IOL, planning a capture. It's important that you don't keep this anterior capsule too small, because if you keep it too small, it can again obscure the visual axis. So initially, because of the intumescence, we had kept a very small anterior capsulorhexis, which we are now enlarging to make a larger size. And having done that, we realized that our posterior capsulorhexis is also quite small. So you can actually, if you pay attention and use your focusing of the foot pedal well, you can achieve such outcomes without causing vitreous disturbance in more cases than none. Of course, you will from time to time encounter vitreous disturbance during doing a posterior capsulorhexis. Now go ahead with the 3-piece IOL insertion. Notice here the technique that we are using here is a holding folding technique and not the injector technique, because 3-piece IOLs through the injector are sometimes quite unpredictable. So you may need a larger incision. Don't be, stingy a slightly larger incision. This is not the case where you are worried about your surgically induced astigmatism. You want a safe delivery of the IOL. So first you make the IOL goes inside the capsular bag. And once that is done, notice how we are pushing this optic through the posterior capsulorhexis margin behind. So that is a posterior buttonholing of the optic through the posterior capsulorhexis, so that the haptics will remain in the bag. We can understand this side of the haptic will not completely stay in the bag. It will be part bag, part circles, because the open capsule is stuck with synechia to this part of the iris. But major part of the optic will be far away behind the iris. That will reduce the contact with the iris and inflammation and everything. It's always important to make sure that you assess there is no vitreous disturbance even at the end of surgery, and there is no better way to do it than preservative-free triamcinolone. Don't rely on pilocarpine and such situations in such a frail and traumatized iris. And this is what the patient looks at the end of surgery. So I want to highlight this concept of optic capture of IOL even in these special cases of traumatic cataract, it helps in making sure that the lens stays in of course, but more importantly, in such cases, it remains as far away from the iris and other damaged structures due to trauma, leading to lesser chances of post-operative IOL-related irritation. And notice this in the bag IOL, where there is always a little bit of space, particularly in half-open bags, where the IOL can keep moving and change from what you end up intraoperatively at the end of surgery, versus once you have locked this IOL or captured this IOL behind the posterior capsular rexus, the position of the IOL is not going to change anytime with that. And this is the patient post-operatively 4 months down the line. And notice this, this dumbbell shape means that the optic is behind this posterior capsular rexus. This is the half-open anterior capsular rexus. And the optic capture also in some ways helps to prevent the PCO from occurring, because the open area of the posterior capsule is covered by the optic now. Another case of a similar nature, 16-year-old boy, firecracker injury before 2 weeks. He also has severe corneal abrasion with stromal scarring and presented to us with hand movement vision. And notice here again the area of open capsule, synechia to the lens, this is the fibrosed open capsule margin that has occurred. This is not because of lack of methylcellulose or fluid on the cornea. The cornea was really bad and abrated in the immediate post-operative period. It's important to stain some of these capsules because you get a fairly idea as to the rest of the capsule where you're trying to create a strong capsular rexus margin. Microincision rexus forceps and rexus scissors. If you don't have it from your retinal, that will help to control the rest of the nerves, and some of these plaques need to be cut. The admin, mute rest of everyone, please. Thank you. Like we saw in the previous case, the lens matter is usually quite fluid and irrigation aspiration alone works. And again, we have a similar situation. If you notice, this is the anterior capsular rexus, but the rest of it is open with synechia here. And we have an intact posterior capsule, fortunately, even in this case. So again, we go ahead with our plan of posterior capsular rexus and create a puncture in the posterior capsule opening. Another important trick to try and prevent vitreous prolapse is to inject a little bit of cohesive viscoelastic behind the puncture that you have created. That will create a space between the posterior capsule tear and the anterior vitreous phase, which is usually solid in these areas. So look, I'm going behind the puncture created and injecting cohesive viscoelastic, which will create that space that will help the vitreous from lesser chances of vitreous prolapse. And slowly but surely, we were able to again convert this into a strong posterior capsular rexus margin all along. Again, do not be stingy with your incision. This is almost a 4.5 millimeter incision created with 3.2 knife. We go ahead with 3-piece IOL in the sulcus, haptics in the bag, as much of the bag that exists as of now. And then make sure once they are in the sulcus or in the bag, you capture it, if you can notice here the margins. And because this was a very traumatized iris, we also decided to do a partial pupilloplasty to have some semblance of a pupil. And acknowledgements to Dr. Amar Agrawal and Dr. Priya Narang for this wonderful technique of single pass 4-through pupilloplasty, which has made pupilloplasty very simple for most surgeons. In the end, of course, confirm with triamcinolone that there is no vitreous disturbance occurring. And this is the patient again at 3 months, very quiet eye. The best part about this approach is patients are very quiet in the anterior and posterior segment inflammation post-operatively for months together, and the cornea has also almost cleared. There is still some amount of anterior stromal scarring, but most of the cornea has cleared and the eye is very quiet. So I think an optic capture is a viable option to be kept in mind in the surgical armamentarium of all cataract surgeons, particularly in such special situations of traumatic cataracts, where the chances of post-operative inflammation, chances of post-operative outcomes being bad due to IOL issues are quite high. There will be, of course, situations in trauma which go very unpredictably. You may have, like this anterior capsule split, you may have a very large posterior capsular split, which may not be able to be converted into a posterior capsular excess. So you may need other strategies as well. You may need to keep a vitreoretinal backup as well in your team in such situations if there is a drop, so on and so forth. So this is just one spectrum of a traumatic cataract, and this is one surgical option that one must keep in mind. And it's not as difficult as it sounds. It's just a matter of mindset of opening the posterior capsule. Otherwise, it's like doing it's like you would do in an intimate capsular exit. At the moment, share regarding sorry, I got logged out in between. So, Dr. Aditya, I just had one question for you. Would you consider recommending an intravitreal intervention or a subtenon intervention in all uveitic cataracts, even if the eye has been quiet for more than 3, 4, 6 months prior to cataract surgery? Or would it be only in cases who have had active uveitis in the past 3, 4 months or so?
Yeah, so if the uveitis has been recurrent, if it has occurred at least over the past 2 or 3, you have seen at least 2 or 3 recurrences in the thing, then yes, I would definitely recommend a simultaneous. And what works best, as Dr. Deepak just mentioned, is intraoperative injection of Ozurdex. Now, typically steroids, we tend to initiate steroid therapy about 3 days to 7 days prior, depending upon physician discretion. So that, and then it continues for over a month. So, it often upsets the metabolic balance of the body. And here you can easily, but of course, the technique of injection is very important. And you don't want hypotony. And we have seen instances of hypotony or other complications arising because of a faulty technique. So that's about it. But yes, if the uveitis has been quiet, there's been only one instance of uveitis, say maybe years ago, you don't always have to inject.
I think there will be no better person than me to know that you need a good injection technique, because I've had an incidence of injecting the Ozurdex inside the capsular bag, rupturing the posterior capsule in a combined case of cataract with Ozurdex. So you're absolutely right. Keep in mind, as if you want to go and hit the optic nerve, keep that direction in mind, and then the chances of hitting the zonules or anything else are very less.
Yeah. And the second thing is you keep the bevel down. When you go in, maybe it can be to the side. I mean, if this is the bevel, you go in along the globe and then you turn it downwards. That is the best way to ensure that the implant reaches where you really want it to be. And you can't really control the intraocular position of the implant. It depends more on the vitreous consistency. But the further away, the better.
Dr. Deepak, I had a question for you, particularly when you highlighted that, when there is a retinopathy active, you must inject first. And when you inject first, you inject anti-VEGF first. So what would you recommend to the cataract surgeon? Is it 2 weeks after the anti-VEGF should we consider surgery? Is it 4 weeks, 6 weeks after the cataract surgery? Do we consider cataract surgery along with the second intravitreal injection? What is it that would be your recommendation?
Yeah, I think first of all, the retinopathy, we need to grade it. So diabetes, let's say, we are talking about diabetes. So diabetic per se, we know the classification goes like non-proliferative or proliferative. So if there is proliferative diabetic retinopathy in the background, you have to make sure the retinopathy settles down. Wait for a while, you can wait a month or so, but keep your retinal colleague in touch whenever you are planning seeing some patient, so that you both, the cataract surgeon and the retinal surgeon, you both are communicating the same message to the patient. Otherwise, patient will get confused. This doctor is saying this doctor is saying that. For non-proliferative, the common scenario is non-proliferative diabetic retinopathy. So non-proliferative diabetic retinopathy, if you are seeing a naive patients, so naive patients, if the cataract is visually significant, the first choice by default, which we have been practicing, is a combined procedures. So concurrent injection. So if the concurrent injection is not possible, maybe if the patient is scheduled for surgery, if he is surgically fit, you can inject at least 2 days prior to it. So sometimes with diabetics, the common problem is whenever you are planning a cataract surgery, sometimes you don't get a surgical fitness because the diabetic profile is haywire. In such patients, you have to make sure always the systemic parameter. Diabetic by default is a systemic disease. So if the systemic disease is under control and the patient is scheduled for surgery, I think a good window period of 1 to 3 days prior to cataract surgery is a good window period which should be taken care of while performing intravitreal injections if you do not have a retinal colleague at your side. If your best thing is to do a concurrent injection because it saves patients time also, and the post-operative, so in these injections can take care of cataract related inflammation also. So this anti-VEGF is also a part of inflammatory mediator. They can also take care of it. So the best thing is these things, and especially more so if the cataract surgery has been eventful. So sometimes you cannot know because like PSC, they have a thick plaques. You may have a PC rupture or anything. So if you have an injection going, sitting down on the steroid, you are a little bit less worried about the post-operative outcomes in such patients. But very valid question. Thank you, Shell, for asking me that.
And do you keep a very strict criteria as far as the pre-operative blood sugar goes? For us as cataract surgeons, we are always 200, less than 200 ppbs, less than this. For injections, do you follow separately or how?
No, by default, generally per se. So injections by default, if you see the Western world. So Western world, if you're seeing a patient who has DME, they will inject in the OPD also. They are not going to check your background systemic status. Unless and until there is gross contraindication. Gross contraindication means there is active infection. Besides retinopathy, there is other comorbidity, systemic comorbidity, which needs to be tackled care. Like a patient has a heart disease, he is not systemically stable. So these parameters, if the patient is systemically stable and there are no any infective etiology, please be aware, see diabetic patients, they are prone to infections. So if there is no any infective etiology in the eye as well as in the system, you can plan a cataract injection. But these injections per se, whatever the practice pattern goes, even if you have an uncontrolled disease, so generally these patients are having retinopathy because they are not maintaining a good systemic control per se. So you are not going to wait for them to have a good systemic control. They will never have it because it's always ups and downs. So for injections per se, it's not mandatory. But if you are planning a surgery, so cataract surgery, if you are taking a patient in a theater and your surgery is going to take a while, and if there's a healing period required, the healing also comes in picture when you are considering in diabetes. So when you have a longer procedure, you can consider a systemic process. But physician fitness is always a must. Always keep a physician in loop to make sure even if the certain things, despite your best efforts, besides your best surgery, sometimes these patients do not fare well. So you need a physician also in hand to communicate to the patient the reason for the patient not doing well. So it's always a teamwork, I believe.
Thank you very much. And once again, thanks to AIOS Scientific Committee, Dr. Partha Biswas and the entire team. Thank you to the audience who has spent their Sunday morning trying to share, interact with all of us. And we hope to see you all next year physically, face to face. Thank you very much once again to the hall coordinators, and we pass on the hall to the next instruction course.
Thank you.
Thank you.